Hello and welcome to the chapter on psychological therapies. In this chapter, we will take a look at the different types of therapy from a broad standpoint because there are actually 400 different varieties of talk therapy or psychotherapy, but generally those are based on the different perspectives that we talked about in chapter 1, humanistic, cognitive, psychodynamic. And so we will approach these different therapies through these perspectives in that sort of general sense. So there are two distinct kinds of therapy. There is psychotherapy, which is therapy for mental disorders in which a person with a problem talks with a psychological professional. In other words, this is talk therapy. So it's treatment in which a trained professional, also known as a therapist, uses psychological techniques to help a person overcome psychological difficulties and disorders, resolve problems in living, or bring about some type of personal growth. And then the other kind of therapy is biomedical therapy. And this is therapy for mental disorders in which a person with a problem is treated with biological or medical methods to relieve their symptoms. So this type of therapy relies on drugs and other medical procedures to improve the psychological functioning of the patient. And actually, if we kind of take a step back to those psychotherapies or the talk therapies, there are two types of psychotherapy: insight and action. So, psychotherapy that is insight therapy is a therapy in which the main goal is really to help people gain insight with respect to their behavior, their thoughts, and their feelings. Whereas action therapy is a therapy where the main goal is to change disordered or inappropriate behavior, and it's more focused and directed on a specific goal. So we talked in chapter 1 about the different types of therapists, so I'm not going to go through them in depth, but briefly, there are clinical psychologists, and these are people that have a PhD or a PsyD and have completed a postgraduate internship. They are able to assess and treat psychological difficulties and disorders. Then there are counseling psychologists, and these people generally have a PhD and treat day-to-day adjustment issues. They usually work in colleges. And then there are the psychoanalysts, who are people with medical degrees and also PhDs and specialize in Freudian therapy and use Freud's techniques, which we'll talk about coming up. And then there are psychiatrists, and as you remember, psychiatrists are medical doctors with a postgraduate training specifically in abnormal behavior, in other words, mental disorders. And they are the only psychologists that can prescribe medicine. There are licensed counselors, and these are people with a master's degree and licensing from the government, either on the national or state level, and they help families, marriages, individuals with any sort of day-to-day problems, but they would not treat mental illness. And then there are social workers, and people that are social workers have a master's degree in social work. They often almost exclusively work for the government, and they treat a variety of family and personal problems. So anything from adoption issues to unemployment issues. So they really... Okay, so the first approach to therapy is the psychodynamic approach. And this approach to therapy is really focused on therapy that seeks to bring unresolved past conflicts and unacceptable impulses from the unconscious into the conscious, where patients can deal with their problems more effectively. So, one of the main focuses of psychodynamic approaches to therapy is looking at Freud's defense mechanisms and seeing how the patients are using them. So, if you remember, the defense mechanisms are the psychological strategies that people use to protect themselves from their unconscious and what they consider inappropriate impulses. Of all of these defense mechanisms, repression is the most common. And anxiety from this can produce some abnormal behavior. So, one of the things that psychodynamic therapies attempt to do is stop abnormal behavior by confronting these conflicts and impulses after they pull them into the conscious from the unconscious of the patient's mind. So, the name of the therapy done using the psychodynamic approach is called psychoanalysis, and this is classic Freudian psychotherapy in which the goal is really to release those hidden unconscious thoughts and feelings in order to reduce their power in controlling a person's behavior. When Freud actually did this therapy, he would meet with the clients a lot, 50 minutes a day, 5 times a week for years. However, this was a lot of time that people had to commit to, and it was very expensive. So today, generally, the sessions last about 3 months or 20 sessions, and they're shorter. And so the client doesn't meet 5 times a week. It's spread out over time, and so it's a little bit more affordable and manageable for people than it was when Freud did it. So, the basic technique in psychoanalysis is to guide patients through their unconscious by starting with their earliest childhood memories and discussing them in explicit detail, focusing a lot on the relationship that the client had with their parents. Eventually, the patients will stumble upon the source of their problem, an experience that caused conflict, crisis, or trauma. And that's kind of the theory behind the techniques that we're about to go over now. However, it is important to kind of understand why when you watch a movie and you see psychoanalysis being depicted, you see the patient lying on the couch facing away from the therapist. And the idea behind that is that if the client can't see the therapist, then maybe they'll kind of start to go off into their own head and be less concerned with what facial expressions the therapist is making or what they're writing down, and feel a little bit freer, and therefore be able to delve into their unconscious without any distractions from their ability to see the therapist. So that's why they face away and lie down on the couch. It's just to try to make them as comfortable as possible. So the first technique that we are going to go over is dream interpretation, and we've actually talked about this before, but what happens in psychoanalysis is that a client will kind of go over a dream that they've recently had that was powerful or profound or important to them with the therapist, and they'll go over it in vivid detail, and it will be the therapist's job to look for the latent content or the true meaning of the dream, and kind of explain the connections between the latent content in the unconscious mind, and to identify what the symbols represent in the dream and how they are just kind of placeholders for unconscious thoughts or urges or feelings. The next technique is transference, and transference is actually something that the patient themselves will do. This is when they transfer their feelings about someone from the past, usually a parent or an authority figure, onto the psychoanalyst. So it sounds a little bizarre, but we've all done it before when we're kind of retelling a story to someone, and we get really into the story, and it's almost like we're reliving the moment, and we start talking to the person that we're retelling the story to as if they are the person that the story originally happened with. So when the patient starts to transfer their feelings onto the therapist, it's the therapist's job to help the patient recreate or redo these difficult past experiences. So essentially, the therapist will start role playing with the client, and this gives that client an opportunity to kind of process through that scenario again in a safe place, and work out maybe what they wish they would have said or how they could have handled it. And then the idea is that once they kind of work through this and replay this moment, that processing through it will help them to kind of mentally resolve the conflicts or the anxiety still associated with the experience. The next technique in psychoanalysis is free association, and this is a technique in which the patient is encouraged to talk about anything that comes to their mind without any fear of negative evaluation. So they are told to just say whatever comes to their mind, regardless of it makes sense, regardless of if it makes sense. And the therapist then makes connections between what they're saying and what's on their unconscious mind. And then the last technique is based on this idea of resistance. So when a person is getting really close to kind of what's at the core of their issues or delving deep into their unconscious mind, they might start to have an inability or an unwillingness to reveal their thoughts or memories that are in their unconscious. They might start changing the subject or shutting down or lying. And so it's the therapist's job to recognize resistance and get the patients to talk, keep them on track, kind of guide them into their unconscious, and not be fooled or distracted by the resistance of the client.
The goal of psychoanalysis is to lead a healthier, more adaptive life by being more aware of what motivates you in the first place, and then living a life in which you might have some chance of getting the good things you want and where you can avoid the things that are pulling you off balance.
It's a big opportunity, really, for a person to rework the way they operate, to rework the way they relate to their feelings, the way they relate to their own history.
The individual freedom and the deep internal transformations that can lead to really living a successful life. That's what psychoanalysis is all about.
Psychoanalysis as a term refers really to three different aspects of what we do. Psychoanalysis is a theory about the human mind and about mental life. The theory, in a nutshell, is that a lot of important things in our lives are determined at a level of our living that's unconscious to us.
I mean, there's an awful lot of human existence and thinking that goes on out of awareness. The psychoanalytic perspective really tries to look beneath the surface.
Most people think about the psychoanalytic psychotherapy or psychoanalysis per se, which is a therapeutic process where one individual who's trained to listen in a special way to another individual tries to bring together and understand these injuries, restrictions, problems from the past.
And generally, over time, you get to piece together what their life story has been and bring into consciousness, really, some of the conflicts that have plagued them.
Sigmund Freud was the fellow who first listened in this unique way. He was very curious. He was a neurologist by training. Gradually, he developed this process of listening and sort of connecting the dots.
The psychoanalyst considers your development as a person, so they see a lot of your problems in the present as reflecting problems in the past.
We don't lay down files of memories. Our memories are sort of stored in kind of neural connections, networks.
The past is always present in some way.
A dream is very important. Freud called dreams the royal road to the unconscious.
What we're creating is a kind of artificial environment where we can attend to things that people spend most of their time trying not to attend to.
Freud grew tired of people sort of looking at him. And he suggested, well, why don't you just lie down?
So he eventually came up with this technique using the couch and having the person free associate.
And it actually makes sense. I know it seems very awkward and maybe very 19th century, but from my own experience being a patient on the couch as well as being on the other, in the other chair, there's something really that frees you up by not having to make eye contact with another person while you're saying very intimate things. Psychoanalysts are, if you will, experts on human development and human behavior. But our job is not to lecture to the patient. Our job is to help the patient become an expert on their own behavior, an expert in listening to themselves.
My relationship with my patient is the most important thing. It's the vehicle, really, for anything good that's going to happen. It provides a second chance to the patient. I provide a relationship which is stable, respectful, where they have my undivided attention. And then I am, skilled at helping them understand what stands in their way.
This isn't like other conversations, and that it's not about you and the other person. It's about you and you. And the other person's job is to help you have this conversation with yourself about yourself. Their job is when you kind of get stuck in that conversation, they kind of help you along.
We value the individuality. We know that if we're really going to help this person, we have to learn about this person.
Psychoanalysis looks at the symptoms not as the problem in and of themselves, but as a sign of a developmental internal struggle.
We really want to understand why the symptoms are there.
The idea is to help a person get past someplace where they're stuck and grow. The third aspect of psychoanalysis, along with the theory and the practice, a form of psychotherapy, is a form of research. The psychoanalytic theory creates many good research questions about how we become who we are and how we operate once we become who we are.
Psychoanalysis is over 100 years old, but since that time, so many other clinicians, investigators of the mind, have discovered additional ways to understand and help people feel freer.
It's a field that is so vast. If I did nothing for the rest of my life but read, I couldn't stay on top of what's being written.
The goal of psychoanalysis is freedom. The goal of psychoanalysis is to help realize the potential for happiness, success, intimacy, to give people choices that they've never had before.
Okay, head on over to Moodle, complete lecture activity number 1, and when you've finished, come back to this point in the lecture video. Okay, the next approach to therapy that we're going to take a look at is from the humanistic perspective. So this approach to therapy is based on the underlying rationale that people have control of their behavior and that we can make choices about our lives and we are essentially responsible for solving our own problems. So the focus then is really on self-responsibility in developing treatment techniques with the therapist. And the therapist sort of acts as a guide, a coach, a facilitator as you attempt to kind of figure out ways to solve your own problems. The belief in humanistic approaches to therapy is that mental disorders result from an inability to find meaning in life, and also from a loneliness or disconnection from other people. So, Carl Rogers is a humanistic psychologist, and he developed his own version of a humanistic therapy called person-centered therapy. And he developed this type of therapy in the 1950s. But the major goal of Carl Rogers' person-centered therapy, and it is also kind of the major goal of all humanistic therapies, is to help a person become self-actualized or reach their full potential. So with the therapist acting as a guide to help the person kind of use this therapy as a way to figure out their own problems, the therapist's job is to provide a warm and accepting environment. And so there are 4 basic techniques in person-centered therapy. The first of which is empathy. So this is the ability of the therapist to truly understand the feelings of their client, to put themselves in their client's shoes, and to kind of be there with the client in the moment, feeling what they feel. It's also very important that the therapist demonstrates authenticity, which is the genuine, open, and honest response of the therapist to the client, creating a sincere environment where the client doesn't feel like they're being talked down to, but that they feel they are being treated with respect and honesty. The next technique is called non-directive counseling, and this is when the therapist doesn't interpret or answer any questions. They just clarify and recite back what the patient says. So it's a form of reflecting or mirroring the client's statements back to them. And the final element of person-centered therapy is what Carl Rogers referred to as unconditional positive regard. And this is when the therapist expresses understanding and acceptance of their client, regardless of their actual feelings or attitudes. It doesn't mean that the therapist approves of everything the client says or does, just that they understand the person, they understand why the person did what they did or feels the way they feel, they understand their intention, and that they accept them, good, bad, ugly, that they are there with the client, not judging them, accepting them as they are. Okay, let's watch a clip of Carl Rogers demonstrating some of these techniques.
Good morning.
Hello,
I'm
Dr.
Dr. Rogers. You must be Gloria.
Yes, I am.
Let's have this chair. Well, we have half an hour together, and I really don't know what we'll be able to make of it, but I hope we can make something of it. I'd be glad to know whatever concerns you.
Well, right now I'm nervous, but I feel more comfortable the way you're talking in a low voice, and I don't feel like you'll be so harsh on me. But
I hear the tremor in your voice, so we are uneasy.
Well, the main thing I want to talk to you about is I'm just newly divorced, and I had gone in therapy before, and I felt comfortable when I left, and all of a sudden now the biggest change is adjusting to my single life. And one of the things that bother me the most is especially men and having men to the house and how it affects the children. And the biggest thing the thing that keeps coming to my mind I want to tell you about is I have a daughter 9 who at one time I felt I had a lot of emotional problems. I wish I could stop shaking. And I'm real conscious of things affecting her. I don't want her to get upset. I don't want to shock her. I want so bad for her to accept me. And we're real open with each other, especially about sex. And the other day she saw a girl that was single but pregnant, and she asked me all about, can girls get pregnant if they're single? And the conversation was fine, and I wasn't at ease at all with her until she asked me if I'd ever made love to a man since I've left her daddy. And I lied to her. And ever since that, it keeps coming up to my mind because I feel so guilty lying to her because I never lie and I want her to trust me. And I almost want an answer from you. I want you to tell me if it will affect her wrong if I told her the truth or what.
And it's this concern about her and the fact that you really aren't, that this open relationship that has existed between you now you feel is kind of
Yes, I feel like I have to
damaged.
be on guard about that because I remember when I was a little girl, when I first found out my mother and father made love, it was dirty and terrible, and I didn't like her anymore for a while. And I don't want to lie to Pammy either, and I don't know.
And you sure wish I could give you the answer as to what you should tell her.
I was afraid you were going to say that.
Because what you really want is an answer.
I want to especially know if it would affect her, if I was completely honest and open with her, or if it would affect her because I lied. I feel like it's bound to make a strain because I lied to her.
Sort of feel she'll suspect that, or she will know something's not quite
I
right.
feel that inside she'll distrust me, yes. And also I thought, well, gee, what about when she gets a little older and she finds herself in touchy situations? She probably wouldn't want to admit it to me because she thinks I'm so good and so sweet. And yet I'm afraid she could think I'm really a devil. And I want so bad for her to accept me. And I don't know how much a 9-year-old can take.
And really, both alternatives concern you, that she might think you're too good or better than you really are.
Yes.
And she might think that you're worse than you are.
Not worse than I am. I don't know if she can accept me the way I am. I think I paint a picture that I'm all sweet and motherly, and I'm a little ashamed of my shady side, too.
I see. It really cuts a little deeper. If she really knew you, could she accept you?
This is what I don't know, yes. I don't want her to turn away from me.
That
And I don't even know how I feel about it, because there are times when I feel so guilty, like when I have a man over. I even try to make a special setup so that if I were ever alone with him, the children would never catch me and that sort of thing. Because I'm real leery about it. And yet I also know I have these desires.
So it's quite clear, it isn't only her problem or the relationship with her, it's in you as well.
And my guilt, yeah, I feel guilty so often.
What can I accept myself as doing? And,
yes.
And you realize that you set up sort of subterfuges so as to make sure that you're not caught or something. You realize that you are acting from guilt, is it?
Yes. I don't like the way, I would like to feel comfortable with whatever I do. If I choose not to tell Pammy the truth, to feel comfortable that she can't handle it, and I don't. I want to be honest, and yet I feel there are some areas that I don't even accept.
And if you can't accept them in yourself, how could you possibly be comfortable in telling them to her?
Right.
And yet, as you say, you do have these desires and you do have your feelings, but you don't feel good about them.
Right. And I have a feeling you're just going to sit there and let me stew in it, and I want more. I want you to help me get rid of my guilt feeling. If I can get rid of my guilt feeling about lying or going to bed with a single man, any of that, just so I can feel more comfortable.
And I guess I'd like to say, no, I don't want to let you just stew in your feelings, but on the other hand, I also feel that this is the kind of very private thing that I couldn't possibly answer for you, but I sure as anything will try to help you work toward your own answer. I don't know whether that makes any sense to you, but I mean it.
Well, I appreciate you saying that. You sound like you mean it. But I don't know where to go. I don't begin to know where to go. I thought that I'd pretty well worked over most of my guilt, and now that this is coming up, I'm disappointed in myself. I really am. I like it when I feel that no matter what I do, even if it's against my own morals or my upbringing, that I can still feel good about me. And now I don't. Like, there's a girl at work who sort of mothers me, and I think she thinks I'm all sweet, and I sure don't want to show my more ornery, devilish side with her. I want to be sweet, and it's so hard for me to, this all seems so new again, and it's so disappointing.
Yeah, I get the disappointment that here, a lot of these things you thought you'd worked through, and now the guilt and a feeling that only a part of you is acceptable to anybody else.
Yes.
That keeps coming out. I guess I do catch the real deep puzzlement that you feel as to what the hell shall I do? What can I do?
Yes, and you know what I can find, Doctor, is that everything I start to do, that impulse, it seems natural to tell Pammy or to go out on a date or something, I'm comfortable until I think how I was affected as a child. And the minute that comes up, then I'm all haywire. Like, I want to be a good mother so bad, and I feel like I am a good mother. But then there's those little exceptions, like my guilt's with working. I want to work, and it's so fun having extra money. I like to work nights, The minute I think I'm not being real good to the children or giving them enough time, then I start feeling guilty again. Then that's when it's a, what do they call it? A double bind. That's just what it feels like. I want to do this and it feels right, but after all, I'm not being a good mother and I want to be both. I'm becoming more and more aware of what a perfectionist I am. That's what it seems like. I want to be so perfect. Either I want to become perfect in my standards or not have that need anymore.
Or I guess I hear it a little differently, that what you want is to seem perfect. That it means it's a matter of great importance to you to be a good mother, and you want to seem to be a good mother even if some of your actual feelings differ from that. Does that catch you?
I don't feel like I'm saying that. No, that isn't what I feel, really.
Okay.
I want to approve of me always, but my actions won't let me. I want to approve of me. I think...
I realize you... All right, because I'd like to understand that. You sound as though your actions are kind of outside of you. You want to approve of you, but what you do somehow won't let you approve of yourself.
Right. Like I feel that I could approve of myself regarding, for example, my sex life. This is the big thing. If I really fell in love with a man and I respected him and I adored him, I don't think I'd feel so guilty going to bed with him, and I don't think I'd have to make up any excuses to the children because they could see my natural caring for him.
Okay.
But when I have the physical desire and I'll say, oh, well, why not? And I want to anyway, then I feel guilty afterwards. I hate facing the kids, I don't like looking at myself, and I rarely enjoy it. And this is what I mean. If the circumstances would be different, I don't think I'd feel so guilty because I'd feel right about it.
Yeah, I guess I hear you saying if what I was doing when I went to bed with a man was really genuine and full of love and respect and so on, I wouldn't feel guilty in relation to Pam. I wouldn't, I really would be comfortable about the situation.
That's how I feel, yes.
The next approach to therapy we're going to look at comes from the behavioral perspective. And so these are approaches that build on the basic processes of learning, such as reinforcement and extinction, classical conditioning, operant conditioning, and behavioral treatment approaches assume that both abnormal and normal behavior is learned. For example, good behavior is rewarded with ice cream so that good behavior will continue. Bad behavior is punished with grounding and that bad behavior will stop. So abnormal behavior, according to this theory, comes from not learning correct skills to cope with everyday problems or learning skills that don't work, faulty skills. So the main idea is that people must learn new behaviors to replace their old bad behavior or unwanted behavior. And so with behavioral approaches, they really use action therapy rather than insight therapy, and they don't feel that there's really a need to look into the past, but instead just focus on fixing whatever the current problem is. So the first set of behavioral therapies we'll look at are using classical conditioning treatments. So you remember classical conditioning and Pavlov's dog. So aversive conditioning is a form of therapy that reduces the frequency of undesired behavior by pairing that undesired behavior with an aversive, unpleasant stimuli. For example, maybe when you were growing up, you bit your nails, and so your parents put hot sauce on your nails or a yucky tasting nail polish. This is aversive conditioning. Or if you cursed and got soap in your mouth, your parents were pairing the swear words with the disgusting taste of soap in your mouth to get you to stop doing the behavior of cursing. So we're going to now watch a very old video with a technique of aversive conditioning being used. This would never be allowed today. Now we have a bunch of laws and things like that that protect patients and people against harmful psychological treatments. However, this was a treatment that was used for people that were looking to change their eating behaviors or habits.
Almost half of all the meals eaten in America are now junk food meals of hot dogs, burgers, shakes, fries, tacos, donuts, pizza snacks, and what have you. This unbalanced diet and hasty manner of eating has become such a major health hazard and nutritional problem that many people are now seeking help and are actually going to aversion clinics, like this one in Florida, to be cured through shock therapy of their lifelong habits and their terrible addiction to junk foods.
Right in there. Is that pretty tight?
That's fine.
Now remember, once they're on, just forget that they're there. You can do anything you want with your hands, okay?
Okay.
Now we're going to ask you to do a couple of things.
All right.
I'm going to turn the machine on, and at first, you're not going to feel anything at all. As a matter of fact, the machine is on right now. Whenever you hear that click, you know it's on. Is there anything on that plate that you'd like to eat?
Sure, I'd love to eat the hamburger.
Okay, pick it up. Go ahead, pick it up. Take a bite. That's it. Go on. What's the matter?
I got a shock.
Pick it up. Come on, you like hamburgers. You told me that.
Yeah, I love hamburgers.
Pick it up and eat it. That's a good-looking hamburger there. Sure is. Take a big bite. Take a nice big bite. I'm going to let you take a bite this time.
Really?
Sure, absolutely. It's going to be a shocking bite, but I'm going to let you. How'd that taste?
I want the hamburger.
See anything else you'd like there?
Now, how about the French fries?
Go ahead. Why don't you pick up a handful? That's it.
Okay.
What's the matter?
I got a shock.
Come on, take some more. Go ahead. You love them. Eat them. Come on. Come on, Gene. We know you like French fries.
No, I don't want any
Really?
French fries.
Come on, Gene. I thought you really loved them. Oh, take a bite. Go ahead. Come on. What do you want to do with those, Gene? What do you want to do with those French fries?
Get them out of my mouth.
What do you want to do with them? Atta girl.
Oh, I can't eat them.
How about something to drink? You've been working pretty hard here. How about taking something to drink? Go on. You like this. How do you feel about chocolate milkshakes?
I love chocolate milkshakes.
Okay. Pick it up and take a drink. Go ahead. Pick it up.
I didn't mean it.
The next type of treatment is systematic desensitization, and this is gradual exposure to an anxiety-producing stimulus, and this is actually paired with relaxation to extinguish the response of anxiety. So they're associating relaxation with the things that make the person fearful or upset. So the very first step in systematic desensitization is to learn relaxation techniques like the ones that we learned in the chapter on health and stress, deep breathing, muscle relaxation. And then the client constructs a hierarchy of fears, which is a list in order of increasing severity of things that the person associates with their fears. So if you take a look at this slide, this is a fear hierarchy for a person that had a phobia of flying in airplanes. So first, you learn to associate each step from the list with relaxation in order, and you do this in therapy. So you might describe the first thing on the list, and as you feel yourself get anxious, you then do your relaxation technique. And you keep going through the whole list, feeling anxious and then relaxing, feeling anxious and then relaxing while you're in therapy, and then you actually do these things in real life in conjunction with your relaxation techniques. The next classical conditioning technique is called exposure treatment, and there are two ways to do this. Graded exposure, which is where you expose a person to the feared stimulus in gradual steps. So like going through their fear hierarchy just without the relaxation, starting with the least scary, and exposing them to that, and then going to the next scary, and so on and so forth. And then there are exposure treatments called flooding, and this is when a person is suddenly confronted with the thing that causes them their anxiety. And so again, there is no relaxation treatment going on. They're just there facing their fears and feeling the anxiety until eventually the anxiety starts to subside, or their brain does what we call habituates, gets used to the anxiety, and then it slowly starts to reduce, and then they no longer fear whatever it was that they were afraid.
The following is a KCRA3 presentation. Tonight on KCRA3 Common Ground.
The nightmare of OCD.
It's like a living hell.
Tortured by compulsive thoughts and rituals, knowing it's irrational but unable to stop. Is facing those fears the answer?
Exposure therapy is the only treatment that actually changes the neurochemistry in the brain.
And it's called Trading Addictions, and it's happening to people who've undergone gastric bypass or lap band surgery.
I mean, the bottom fell out of my world a little over 2 years ago.
Celebrating different backgrounds, experiences, and views to create a better community. Honored for excellence in public affairs and cultural journalism. This is KCRA3 Common Ground.
Good evening. Thanks so much for joining us for this edition of Common Ground. I'm Adrienne Bankert. Tonight we're going to be taking a look into OCD, or obsessive compulsive disorder. It's a disorder that affects up to 2 million people in the United States alone, where people wrestle with thoughts and obsessions that drive them to create repetitive actions and rituals to deal with their anxiety. But there are treatment options available for OCD sufferers. One option is exposure and response prevention. Common Ground's Deirdre Fitzpatrick shows us how it works.
Mom always told you to look both ways before you cross the street. It was meant to create a healthy sense of fear. But when that fear turns to terror,
My brain feels like it's in turmoil, like I'm having some kind of a nightmare.
terror is so intense it leaves you paralyzed and homebound.
It's like a living hell.
It could be obsessive compulsive disorder. Linda Reisenstein suffers from OCD. It began early in life and went undiagnosed for decades. Her most recent obsessive thought, running into traffic and getting hit by a car.
It started 5 years ago, and I was in the hospital, Psych hospital, and one of the other patients said that one day she just felt like she should just walk across the street in traffic, and that was it. That was the zinger.
From the time she woke up until she fell asleep, one obsessive thought.
I have this fear that I'm walking down the street and then I'm going to step into the road while the cars are coming.
OCD is about obsessive thoughts that a person has that they find intrusive and distressing, that they cannot control.
Dr. Robin Zazio runs the Anxiety Treatment Center in Sacramento and sees firsthand how crippling the disorder is.
We believe it's due to a chemical imbalance, that something happens in the brain.
OCD fears are individual, but all have a similar component.
As a result, they develop what are called compulsive behaviors or compulsions or rituals that are designed to try to neutralize or make those thoughts go away.
Compulsions like excessive hand washing or repetitive actions keep anxiety at bay, but they leave the OCD sufferer trapped in a vicious cycle. Dr. Zazio helps patients like Linda break the cycle with a form of behavior therapy called exposure and response prevention.
We have them begin to confront the fear by exposure to it. Exposure therapy is the only treatment that actually changes the neurochemistry in the brain.
An idea that was terrifying to Linda.
And I thought to myself, they're crazy. They don't know what they're talking about.
After a series of sessions that started with a simple step off the curb and worked up to crossing a deserted street, Dr. Zazio and Linda are moving to a high-traffic intersection. On a 0 to 10 scale, crossing the street is a 10.
If you were walking across the street completely by yourself, what would your anxiety level be?
Probably 10.
It would be a 10.
Yeah.
And so walking across with me is an 8?
Yeah. How many times do I have to do this?
Well, until that 8 goes down, right? Because ideally we want to get to a place where you can walk across the street by yourself.
Back and forth.
You're walking really fast all of a sudden. Okay, we're going to try not to walk too fast because you want to sit with the fear as we're walking across the street that someone's going to hit us.
Crossing the street until it's so monotonous.
So let's try it again and see what happens.
Are you going with?
I'm going with you, yes.
The obsessive fear subsides and the brain is retrained.
Do you want to do it alone now?
I can do it alone.
Still, after weeks of therapy, the idea of crossing the street alone makes Linda anxious.
And I want you mentally to be calling up the fear that you're going to be hit by a car.
Just get green already so I can do this.
Something we all take for granted is a major milestone.
Your anxiety started at an 8. Where did it end up?
It ended up at a 4 because it was a baby street.
OCD is a lifelong struggle for many, but the tools learned through exposure and response prevention keep that disorder in check.
The earlier you catch it, the quicker it'll go away.
Linda continues to work with Dr. Zazio, and she's back at work, able to cross streets with little or no anxiety.
I can handle it.
Deirdre Fitzpatrick for Common Ground.
Dr. Robin Zazio, a team of professionals and OCD patients, created the OCD Sacramento Foundation to raise awareness about OCD and related disorders. Once a month, they hold a class dealing with topics ranging from anxiety to hoarding and OCD medication, and all classes are open to the public.
Okay, so also under the behavioral approach are operant conditioning techniques. And we remember that operant conditioning is all about rewards and punishments. This was the theory developed by B.F. Skinner. The first operant conditioning technique we're going to talk about is called a token system. And a token system is when you reward someone with some type of token. For example, play money, or stars, or tally marks, or points, and then later they can trade those tokens in for an actual reward. So the tokens then are just placeholders that are given to them for their good behavior, and then once they collect a certain number of tokens, they exchange those for an actual tangible reward. Maybe that's snacks, or being allowed to engage in some activity, or staying up later, at bedtime. And so we often use token systems with children or in mental institutions or with people that are looking to modify some type of behavior. So maybe with a child, if you use those kind of sticker charts, you tell them exactly what you want them to do. Clean their room, make their bed, brush their teeth, and each time they do the good behavior, they get a token, maybe in the form of a sticker or a point value, and then once they get a certain number of stickers, then they get an ice cream cone or, like I said, to stay up later or something like that. The next operant conditioning technique is contingency contracting, and this is when the therapist and the client draw up a written agreement that specifically states the client's behavioral goals. And there are tangible positive and negative consequences that will occur if you follow the contract or if you don't follow the contract. So, for example, I knew a psychologist who used contingency contracting, and she had a client that was working on something. I don't remember what the behavior it was that he wanted to change. But one of the things that he personally disliked were guns. And so as part of his contingency contract, the therapist had the client write a check to the National Rifle Association, and if he violated the contract, she was going to send the check off to the NRA. And finally, the last technique is observational learning, and this is when the client models others' behaviors to teach new skills or new ways to handle their anxiety. And one kind of sub-technique under observational learning is what's known as the fearless peer. And this is when you have someone watch someone that looks like them or is the same age as them engage in the anxiety-producing stimulus that they're afraid of. So if they were afraid of a snake, they would watch someone that looks like them play with the snake, interact with the snake, and see that that person is perfectly fine. And then there is the cognitive approach to treatment, and this is when treatment approaches teach people to think in more adaptive ways by changing their dysfunctional cognitions about the world and themselves. So actually, cognitive treatment approaches use a lot of behavioral strategies, but mostly they encourage their clients to challenge their thoughts and assumptions and adapt new approaches to old problems. And sometimes that's where the behavioral strategies come into play. So this type of therapy is short term. It lasts a max of 20 sessions. It's highly structured and it focuses on a specific problem. The therapist explains the theory behind the approach to the client and then acts as their coach, their friend, their partner as they guide them through the sessions. So the specific therapy under the banner of cognitive approaches is rational emotive behavior therapy, often referred to as REBT. And this type of therapy was created by Albert Ellis, who believes that many people are unhappy because they hold unrealistic beliefs. So in rational emotive behavior therapy, it's attempts to restructure a person's belief system into a more realistic, logical set of views. So some of the unrealistic beliefs that Albert Ellis says that people that are unhappy hold are the need for love and approval from everyone for everything that we do. Another unrealistic belief is that we must be successful at everything to be considered worthwhile. And then another very common unrealistic belief is that it's horrible when things don't turn out the way that we wanted them to turn out. So these irrational beliefs trigger negative emotions, which then support those irrational beliefs. And so this is the ABC model that you see on the slide. So in rational emotive behavior therapy, the therapist will attempt to poke holes, actually argue or debate in the patient's reasoning and eliminate their maladaptive thoughts. So let's watch Albert Ellis demonstrate rational emotive behavior therapy.
What is your first name?
My name is Beth.
Beth. What problem would you like to start with, Beth, before I and the audience give you other problems?
Gosh, I wasn't thinking problem, but does it have to be a problem, or can it be like feelings I have about something that troubles me?
Something that really troubles you, something live. It doesn't have to be ancient, it could be modern, but anything that you're troubled about these days and you feel anxious or depressed or angry or upset about.
I have a lot of, I guess, sad, troubled feelings about my relationship with my mother.
All right, let's take that. And do you have them at all times, or when she does something that you don't like?
Well, she lives far away from me, and so I'm not around her very much. But when I talk to her on the phone, when I think about her, I feel very troubled.
But could we take the word trouble and break down? Do you mean angry at her, or depressed, or anxious about what she might think of you, or what? What's the troubled feeling? Give us a recent incident where you talked to her over the phone and you felt troubled.
She's real complicated. Actually, I think she has maybe like schizophrenia or something. I'm always trying to figure her out. She's not all there. I mean, there's so I'm always feeling, I'm not sure whether to be angry or to feel hurt or to feel protective of her, or, so I have to keep myself at a real distance.
Well, was there a recent time, or it even could be in the past, when you felt angry about her being confused? All right. And what happened then when you felt angry?
She called me on the phone, and I was busy writing a paper, and so I was feeling anxious anyway. And she wants my sister to belong and practice a certain religion. And my sister doesn't want to. And my mother continually sends her things, calls her, tries to get her to do this. And
sometimes she does the same thing to you, or mainly to your sister?
It's mainly to my sister.
I see. Is she a younger sister?
Yes.
Right. All right.
I'm sorry. I said, why can't you just leave her alone and accept her the way she is?
Right.
And my mother started yelling, and I started yelling, and finally I hung up on her.
All right, so I think that's fairly clear and maybe typical, that not all the time, but some of the time your mother gets after your sister particularly, and not only gets after her, but keeps persisting that your sister must do what your mother wants her to do with religion or anything else. And then when you hear that and see that, you feel angry at her.
Yes.
Because at that point, what do you think you're saying to yourself? Not just to your mother or your sister, but to yourself, to make yourself angry, because we control our feelings and we make ourselves angry or hurt or whatever. What do you think goes on in your head while your mother is doing this?
There's also what's known as Beck's cognitive therapy, and this type of therapy is a little bit less challenging and confrontational than rational emotive behavior therapy. It encourages patients to change thinking on their own. And one of the main techniques in Beck's cognitive therapy is cognitive appraisal. And so in cognitive appraisal, clients evaluate situations. They evaluate themselves, they evaluate others in terms of their memories, values, beliefs, thoughts, and expectations. And so by evaluating other people that are going through similar situations that they're going through, sometimes they can kind of give advice to those people or see the errors in those people's thinking. And then the methodology in Beck's cognitive therapy is to have those people kind of flip that cognitive appraisal from someone else back onto themselves. So the idea is kind of like, well, you can see what this person needs to do, and they're in the same situation as you, so what do you think you should do?
The first case that I cited a lot was a chap who was a writer, and when he came in to see me, I said, I've read a lot of your writings, and once, I really am one of your fans. And then he looked very sad, and as I recall, he started to weep. And I said, "Oh, what's the reason for that? What went through your mind?" He said, either you're a charlatan by thinking my writing was good, or you're stupid for thinking it was good, or you never read my writing. And then I realized at that point that I had missed the boat. This guy is depressed, and you've got to be real careful about what you say to depressed patients, at least at the very beginning. But anyhow, so he went on and came in therapy, and in one of the sessions, this was a subsequent session, he said that he thought he got to commit suicide because he's a total failure. And I said, well, what way are you a total failure? He said, well, my wife was very cross today, and it's obvious she doesn't love me, and that I just can't make it as a husband. And the kids my teenage kids were making a lot of problems, and the roof was leaking, my house is coming apart, and my business is going to pot. So I said, well, let's take them up one by one, looking for alternative explanations. And so I said, is there any explanation with why your wife was cross other than that she didn't love you anymore? And then he thought, he said, well, yeah, the kids were really acting up, and I guess, now I remember she was annoyed at them. So then I said, well, your kids are acting up. Does that make you a bad father? I said, well, yeah, I guess it does. And I said, well, I guess all fathers in the world must be bad because all teenage kids act up. And he kind of smiled. He said, okay, and that. And then he said, my house is coming apart. The roof is leaking, and so on. So I said, well, if your roof is leaking, does that mean that the house is coming apart? He said, well, if it's not the roof, it'll be something else. So I said, well, what can you do about it? And he said, well, I guess I could get a roofer in to take a look at it. And I said, is there evidence that there's anything else? And he said, well, I guess not. And then I said, what about your business? Well, what about the sales of your books? So he said, well, the sales have been down a lot lately. But I said, how long has your book been out? He says, it's been out for 5 years. It just come out in paperback. So he said, well, is it possible that the reason people start buying the hardcovers because they're buying the paperback? And he says, you know, you're right. So anyhow, now I'll tell you about more.
Can I just interrupt you for 1 second? So those other explanations sound so obvious to us. Why didn't he see those without your help?
Well, first of all, what I'm doing is I'm condensing just to start with because he doesn't see it right away. So I had to use a little artistry to get to that point. But the thing is, when you're depressed, when a person is depressed, they have a one-track mind. They cannot see anything outside of this little prism or lens or tunnel. They can only see straight ahead. And therefore, kind of the walls of this tunnel vision that they have preclude other information from coming in. They're not able to use their rationality, they're able to use it in reference to their dysfunctional thinking because they don't have access to it. So basically what you're doing is you're then activating the patient's own access to this type of thing. And it's not unusual for people who are functioning normally to think of alternative explanations or to think of the logical aspect of things. But when they're depressed, they simply don't. And you have to break through the wall to give them access.
Another type of therapy is called dialectical behavior therapy. And this is a treatment where the focus is on getting people to accept who they are, regardless of if who they are matches their ideal self. So dialectical behavior therapy, or DBT, uses Zen, Buddhist, and mindfulness techniques plus cognitive behavioral therapy. It's most commonly used to treat borderline personality disorder and self-injury or self-mutilation. The main idea is if you had a bad childhood or bad experience in relationships, that's in the past. Who do you want to be going forward? Who are you in this moment right now? Your options are really to remain unhappy or change. That's the bottom line. So patients are taught that if they experience negative emotions, that they should not let them rule their behavior, that they can pick and choose which emotions to pay attention to and which to ignore. And they're taught behavioral skills that help them behave more effectively and keep their emotions in check, primarily by focusing on staying in the present moment and being mindful of what's going on in the here and now, and not thinking about the past or thinking about the future, but just living in the now. Okay, go ahead and pause the video here. Head on over to Moodle, complete lecture activity number 2, and when you've finished that, return to this point in the lecture video. So while there are different approaches to therapy, regardless of the approach that a person uses, there are also different formats to therapy. So different ways that the therapy can be set up, who's involved, who's not involved. So there's what's known as interpersonal therapy, and this is short-term therapy that focuses on the context of current social relationships. It focuses on conflicts with other people, it focuses on social skills issues, divorce, grief, and its roots are in psychodynamic approaches, but interpersonal therapy is shorter, more direct, it considers current contexts, and it's very structured. So it doesn't look at your past or your childhood. It doesn't incorporate free association or anything like that. So therapists make suggestions on improving relationships with others. They offer recommendations, they give advice, and it's usually a one-on-one format where it's just the client and the therapist. So while interpersonal is just one client and the therapist generally, there's also group therapy, and this is therapy in which people meet in a group with a therapist to discuss problems. Usually the problems are shared amongst the members, so they all have addiction issues or they all have depression, but they have some common reason that they're going to this therapy. And group members provide emotional support to one another. They discuss coping methods that work for them. There are groups for each psychological perspective, so there's psychodynamic groups, humanistic, etc. And the therapist can set the rules, or the group can collectively decide how the sessions will go. So the pros of this format are that it's much cheaper and can be comforting to know that other people have the same issues as you. But the cons are that you lose that one-on-one attention, and shy people tend to be less receptive to the group therapy format. And then there is family therapy, and family therapy is an approach that focuses on the family and its dynamics. It involves 2 or more members of the family where at least one member's problems led them to treatment. It's not an intervention for one of the members, but the therapists look at the whole family unit to see the patterns of interaction and the behaviors that go on within the group. Each family member is expected to contribute to finding a resolution, and family therapy believes that each family member takes on a role, the bully, the scapegoat, etc. So they try to get families to find more productive roles or patterns of behavior than what they're currently doing. There is also self-help therapy, which can just be a person taking the initiative to try to gain insight into their own behavior, either through self-help books, or there are group therapies without a professional therapist, like bereavement support groups or AA or Narcotics Anonymous, and these can be just as effective as other therapies. It just depends on the commitment of the person doing the self-help program. So a question that many of my students ask is therapy effective? Well, until 1952, people assumed that therapy worked. But then a man named Psych published a study claiming that people receiving treatment were no better off than those who did not receive treatment. So there is a term that he used called spontaneous remission, and this is recovery without treatment. So Psych coined this term for the people in his study who never got therapy and were left alone. However, several studies have been done since Psych's study in 1952 that indicates that therapy does work. In most cases, the symptoms of abnormal behavior would not go away without treatment. With that said, psychotherapy doesn't work for everyone, and no single form of therapy works best for every problem. Certain types of treatment work best for specific types of problems. Most therapies share several basic similar elements, but it is important to try to find a therapist that matches the client's perspective. So you wouldn't really want to pair a humanistic therapist with a person who maybe would respond better to the psychodynamic perspective. So now we're going to look at the other major branch of therapy, biomedical therapies. So these are biological approaches to mental disorders, and they have been revolutionary. Patients in mental hospitals are now less violent, and it's easier to actually help patients using these biomedical therapies rather than just kind of locking them up in a mental hospital and babysitting them. So patients with depression or anxiety are able to function better in their daily lives than ever before thanks to biomedical therapies. They don't represent a cure-all. They provide relief of symptoms, but they don't solve underlying problems. And in some cases, they can create even new psychological problems. However, in conjunction with therapy, medicine in particular has been effective in treating millions of people. So ultimately, whether or not medicine or therapy or both will be effective depends on each individual client.
We can start by dividing therapies into 2 major groups, the biomedical approach and the psychological approach. Biomedical therapy focuses on changing some aspect of our physical functioning. This approach is based on the premise that certain mental disorders are diseases and that treatment must be biologically based to reverse or eradicate them. Sophisticated imaging techniques like this CAT scan are often used to pinpoint the problem. Biomedical therapists are psychiatrists, neurobiologists, and others who specialize in isolating and identifying specific disease states that are assumed to underlie depression, schizophrenia, and other mental disorders. Because the ecology of the mind is held in such a delicate balance, it can be upset by biochemical events. Mental disorders are assumed to be the observable end products of these disturbances. One of the most radical treatments in the biomedical approach has been psychosurgery. The best-known form of psychosurgery is the prefrontal lobotomy, cutting the nerve fibers that connect the brain's frontal lobes with its thalamus. The typical candidate for a lobotomy was an agitated schizophrenic or someone with extreme compulsions and intense anxiety. The operation eliminated these symptoms by, in effect, disconnecting the individual from traumas of the past and anxieties about the future.
You tell me a little something about yourself. You were 19 years old.
That's right.
And you were in a first-year college.
That's right. Catholic Sisters College.
Speak up.
Catholic Sisters College. The other place is Peabody University in Baltimore.
Now, you got sick about when? Do you remember?
When did I get sick? About sometime in June.
And what happened to you after you went to the hospital, you know?
Uh-huh.
What was it that happened to you?
I was fighting in a war.
What sort of war was it?
First of all, it was the Christian War.
But the operation also took away the ability to remember clearly and plan ahead. Emotional flatness, childlike emotions, and a lack of concern for the opinions of others replaced earlier symptoms of guilt, anger, and anxiety. Because the cure was often worse than the illness, its use is now restricted to only the most extreme cases where no other treatment has helped. Another controversial biomedical treatment is electroconvulsive therapy, or ECT. Shock therapy, as it's known, has been hailed for its effectiveness as the most powerful antidepressant treatment available for patients who can't tolerate medication. Although misuse of ECT has been criticized for causing memory loss in some patients. As effective as shock therapy can be, it can only help a limited number of people. The real revolution in biomedical therapy, the treatment that has reached the greatest number of people, has been the use of drugs to treat mental and behavioral disorders. When I was a graduate student back in the 1950s, before the advent of drug therapy, I visited a mental hospital for the first time. It was a horrible sight. Patients screamed constantly. They exhibited themselves. They exploded in violent rages. They smeared excrement on the walls. Some withdrew into zombie-like states, while others had to be put in straitjackets to keep them from hurting themselves or other patients. But all that changed in the mid-1950s with the advent of tranquilizing drugs.
I hear voices.
Chlorpromazine was the first miracle drug that worked on many of the symptoms found in schizophrenic patients: delusions, hallucinations, social withdrawal, and agitation. Another antipsychotic drug, lithium, regulates the extreme mood swings of manic depressive disorders, while anti-anxiety drugs relax and tranquilize patients. Drug therapies not only suppress the symptoms of mental disorders and bring relief from suffering, but also make it possible to use psychotherapy with patients who previously could not be reached. The danger with drug therapy, however, is that overworked hospital staffs may merely tranquilize their patients and leave it at that, or that individuals may over-medicate themselves to cope with everyday life. Valium, the nation's most popular tranquilizer, is also addictive. It's taken every day by over 8 million Americans, many of whom have given up on trying to deal with the sources of their stress.
So we'll start our discussion of biomedical therapy by talking about drug therapy. So drug therapy is control of psychological disorders through the use of drugs. And these drugs work by altering the operation of neurotransmitters and neurons in the brain. So they either inhibit neurotransmitters, which reduces activity, or they increase production, making more activity. Antipsychotic drugs are drugs that temporarily reduce psychotic symptoms such as agitation, hallucinations, and delusions. Generally, they're used in mental institutions to treat severe psychological disorders like schizophrenia. However, we didn't have these type of drugs until the 1950s. Most antipsychotic drugs block dopamine receptors. And there are what are known as atypical antipsychotic drugs that affect both dopamine and serotonin levels in areas of the brain related to planning and goal-directed activity. Atypical antipsychotic drugs are especially useful with schizophrenia. So these drugs do not produce a cure. When taken off the drug, symptoms do reoccur. Some of the long-term side effects of using antipsychotic drugs include dry throat, dizziness, tremors, loss of muscle control, appetite changes, sexual dysfunctions, etc. So, antidepressant drugs are medicines that improve a severely depressed patient's mood and feeling of well-being. Antidepressants are also used for anxiety and bulimia. They're also used to help with sleep disturbances sometimes. Overall, their success rate is really good. They can produce long-term lasting recovery from depression, even after the patient stops taking the medicine. However, side effects can include drowsiness, faintness, nausea, diarrhea, sexual dysfunction. Consumers spend billions of dollars on antidepressants every year, especially Prozac. And Prozac is the most consumed antidepressant because it is particularly effective and has the fewest side effects. There is an herbal medicine that students often ask me about called St. John's wort. It is used to treat depression. However, research does not show that it's effective. So let's go ahead and watch this video on antidepressants.
The human brain has about 10 billion brain cells. Each brain cell can have as many as 25,000 connections with other cells. Messages, which direct many functions throughout your body, travel through your brain from cell to cell through these connections. For these signals to move from a sending cell to a receiving cell, they must cross a small gap called the synapse. Chemicals called neurotransmitters, located at the ends of the sending cells, help the signal cross this gap. Serotonin is one such neurotransmitter, a very important one that helps regulate mood, emotions, and other body functions. After the serotonin has done its job, it's reabsorbed by the sending cell and is soon back in position to help with the next nerve signal. If you have depression, you may have a serotonin imbalance. Your overall level of serotonin may be low, and some of it may be reabsorbed too soon. As a result, communication between the brain cells is impaired. An SSRI, or selective serotonin reuptake inhibitor, is a medication designed to help increase the amount of serotonin in the synapse by blocking its reabsorption. As serotonin builds up, normal communication between cells can resume, and your symptoms of depression may improve.
So now that you've seen how antidepressants work, let's talk more about their usefulness.
Doug, when should a person consider taking antidepressants?
A person should consider taking antidepressants when the 5 areas of therapeutic self-care we talked about earlier aren't working. It's your kind of your backup tool. And so when you're doing the right things and you're still feeling crummy and you still can't get out of bed and you're still sleeping, your sleeping is still messed up, and your biochemistry, is messed up and you feel like crap, then a prescription may be helpful.
And what are the different kinds of antidepressants?
Well, all antidepressants work theoretically because they're rebalancing the chemical structure in your brain, the neurotransmitters. There are three basic classes. The first are called the tricyclic antidepressants. They came around in the 1950s when I was growing up. Things like Elavil and Tofranil, the Zipramine, Pamelor, things that probably your listeners haven't heard of because they're hardly used, but they're just as effective as the newer drugs. The second ones are even more obscure. They're called the MAO inhibitors, Nardil and Parnate, but the ones that most people have heard of are the SSRIs, Prozac, Zoloft, Paxil, Celexa, Lexapro. These are the ones that basically target the neurotransmitter serotonin, the feel-good one. And there's a fourth class, they're called atypical, Effexor and Cerazone and Wellbutrin fall in that class. So there's, as you can see, there's a whole bunch to choose from. Now here's the key. No one knows which ones are going to work until you try them. You've been through this, right? It is all a bunch of trial and error. I went to the top psychiatrist in Portland when I was really struggling, and he said to me, you know, no psychiatrist likes to say this, but you're all a bunch of guinea pigs. We don't know what's going to happen until you take the drug. But there's a lot to choose from.
What should I expect when I first take an antidepressant?
Well, the first thing you should expect is that you're not going to get high. It's not something that, you know, gets you high like, you know, a drug or alcohol. Now, interestingly enough, the father of psychoanalysis, Sigmund Freud, thought he had found a cure for depression when he took a substance called cocaine, right? Because, you know, we've all heard of it, right? Maybe some of us have even taken it. But what does cocaine do? It's a stimulant, right? When a person is depressed, are they happy? Do they have energy? Or no, just the opposite, right? So he took this stuff and he said, oh my God, I can't believe how up I am. I can't believe all the wonderful thoughts I'm having. I can't believe how little sleep I need. I can't believe how productive I am. This is the cure. This is the cure of depression. He even wrote a paper on this. Unfortunately, a paper on cocaine. Unfortunately, then he discovered the problem with cocaine and other stimulants like it. What goes up must come down. He should have consulted Isaac Newton, right? So that's not how the antidepressants work. Unfortunately, or I should say fortunately, it's much more subtle than that. But it takes 4 to 6 weeks for them to really kick into place. So during that initial time, you're going to have to be patient. Oftentimes there are side effects that you have to get through first. Usually they'll go away in 3 or 4 days. For those antidepressants where there's a lot of stimulation or activation that happens, sometimes psychiatrists will give you a tranquilizer like Xanax or Klonopin or Ativan to take the edge off. Sometimes you have to add a second one, have a cocktail. Sometimes you're starting like at 20 milligrams of Prozac and you have to bump it 30 or 40. So it's really, you know, it's hit and miss, trial and error, as I said earlier. But you have to give it time.
All right, how long should I take my medication for?
You should take your medication as long as you need to. Now, what do I mean by that? Well, first of all, as I said just before, that it takes time for these things to work, and you know, oftentimes just have to tinker around. So let's assume that now it's 2 months down the line and you're starting to feel better. You're coming back to your old self. You feel you're old, your energy is coming back, your sleeping is better, maybe even your sense of humor. You know, some of your listeners or viewers may relate to this, but when I was really depressed, I lost my ability to laugh. That's like a curse when you can't even, you know, laugh at a good joke or a funny movie. So as all that starts to come back, then you have to make a really critical decision. Do I continue taking the antidepressant or do I stop, right? You've been just dealing with that recently, right? So normally what will happen is when the person starts to feel better, they start to think, okay, maybe I don't need it. And now if you're going to go off an antidepressant, make sure you do it under the auspices or the direction of a psychiatrist or a nurse practitioner. Do not go cold turkey. Some of them, like Paxil, you can have some really bad side effects. So you taper off, and when people do that, I've observed in my clinical practice, one of 3 things happens. One, you go off the antidepressant and then you're still stable and you never have another episode. The second possibility is you go off the antidepressant, you're stable, but maybe 6 months later or a year or 2 years later, it comes back, because depression, for the most part, is a recurrent disorder. In that case, you go back on the antidepressant or try something else, and usually you can restabilize. The third option or possibility, which doesn't happen very often, but I've seen it happen, is you go off the antidepressant within a month, or not even a month, within days or weeks, you're feeling messed up again, and then you have to go back on. So some people have to stay on an antidepressant for a long period of time, even though they would rather not. Some people can never go back on it, and some people can be off it for a while and then come back later on. So there's all these possibilities. You don't know what's going to happen until you take them, but the thing is, take them till you feel better, And if you feel like tapering off, talk to your doctor and see what you guys can do.
Mood stabilizers are drugs used to treat mood disorders that prevent the manic episodes of bipolar disorder. Lithium is a highly effective medication that has been used in treating manic episodes of bipolar disorder. However, this does not treat the depressed episodes of bipolar, so antidepressants are prescribed for those episodes. There are other mood stabilizers out there besides lithium. That's kind of an older medication. However, mood stabilizers are unique in that they can be preventative and block future episodes of mania. And so you can take a daily dose of mood stabilizers to prevent the reoccurrence of manic symptoms. There are also anti-anxiety drugs, and these are drugs that reduce the level of anxiety a person experiences, essentially by reducing excitability and increasing feelings of well-being. So anti-anxiety drugs reduce tension for temporary difficulties and long-term anxiety disorder. Valium and Xanax are examples of anti-anxiety drugs, and more than half of U.S. families have had someone that has taken one of these at some point in their lives. The side effects of anti-anxiety drugs can include fatigue and dependence. And what we've seen recently is a increase in deaths of people using anti-anxiety drugs in combination with alcohol. Most psychologists, though, view anxiety as a signal of a deeper psychological problem and believe that anti-anxiety drugs just mask that instead of having the patient confront the source of the problem. So generally, when they're prescribed in conjunction with a recommendation to psychotherapy. And finally, in biomedical therapies, there are some alternatives to drugs. The first is electroconvulsive therapy, and this is a procedure used in the treatment of severe depression, in which an electric current of 70 to 150 volts is briefly administered to a patient's head. And this is based on a theory that depression is due to overactivity in the brain. And electroconvulsive therapy slows down brain connections. It can cause a loss of consciousness and even seizures, so usually the patients receive a muscle relaxer before they receive the shock. They usually receive 10 treatments in a month. However, this type of treatment is very controversial, and side effects can include disorientation, confusion, and memory loss that can last for months. It usually does not result in long-term improvement, and when it does work, it actually may be the result of brain damage. However, people use it because it's a fast solution for patients that may harm themselves otherwise, especially patients that are suicidal and don't have time to wait for drug medication to start working, because antidepressants can take up to 6 months before a patient will see any positive effects of it. 100,000 people actually undergo electroconvulsive therapy each year, and popularity has actually risen in the last decade. It's generally used when other techniques, particularly medications, have failed. There's also what's known as transcranial magnetic stimulation, and this is a treatment for depression in which a precise magnetic pulse is directed to a specific area of the brain. It activates particular neurons and has been found to relieve symptoms of depression by increasing neurotransmitter activity. It's still considered experimental by the government, and some negative side effects are that it can produce seizures and convulsions. So let's watch a video on these types of biomedical therapies.
Major depressive disorder is common, affecting approximately 15 million Americans in a given year. Depression, unlike sadness, is not a benign condition. It affects mood, sleep, appetite, thinking, and the overall ability to function. Of these 15 million living with depression, only half seek treatment, and many do not respond to medication.
Depressive disorders are disorders of the brain. We believe that neurotransmitters, or chemical messengers that brain cells use to communicate with, are out of balance in depression. Also, brain imaging studies like MRIs or PET scans show that brains of people that are depressed look different from those who do not suffer from depression. Depression is treatable, and there are many people who respond to medication. There are 4 million Americans who either do not respond or have side effects that they cannot tolerate with the antidepressants. Some people experience nausea, fatigue, sexual dysfunction, or weight gain. For those people who don't respond to medication, researchers have found a way to treat depression without using drugs.
Dr. Centurion is a board-certified psychiatrist and psychopharmacologist specializing in addictions, anxiety, and mood disorders. She uses new biological therapies along with medication to increase response rates in her patients. TMS therapy is a non-systemic and non-invasive system used to treat major depression disorder. It is approved by the Food and Drug Administration for patients who have not benefited from prior antidepressant treatment. Using highly focused magnetic pulses to stimulate function in the targeted brain region thought to control mood, the treatment goal is to activate brain cells non-invasively without anesthesia or sedation. Patients remain awake and alert throughout the session, able to resume normal life activities immediately after treatment.
TMS is a non-invasive treatment that uses pulsed magnetic fields. These magnetic fields are converted into electrical fields that activate an area in your brain located in the left prefrontal cortex that we believed is involved in mood regulation. This area is about 1 square centimeter. TMS therapy is actually a more specific and targeted treatment for depression than medication. Patients receive treatments 5 days a week, approximately an hour a day, and they are alert and awake during the procedure. They can actually drive themselves to treatment and drive themselves back to work. I've been using TMS on my patients for approximately 2 years, and I've seen success rates of 80%.
I think I've been depressed my entire life, but I really noticed it after I had my 4 children. And I started losing interest in a lot of the things that I loved, like gardening. I was working at the time, and I was able to function and work, but outside of work, I really started to retreat. I noticed that I couldn't get up in the morning. Even I was working, but I had tremendous anxiety, and I kept trying different medications. And I probably tried 3, 4, 5 different medications, and none of them really worked. When I was having the treatment, I would say I started to see a difference within the first 2 weeks. I could feel myself getting lighter, and then by about 4 weeks was a real difference. And also my family saw a difference before I even did. They would say things like, "You're different, you're lighter." It's pretty amazing.
When I see patients, they are generally in a state of despair. They have failed not only one, but multiple antidepressant treatments. And I have seen marked improvement even during the course of treatment, so that they look like different people by week 5. People get their relationships back. They're able to work. They're able to enjoy their children. They're able to enjoy things that were once a passion. It is certainly very gratifying.
It's been a year since my last treatment, and I feel great. And I also have a lot of things that I've had to deal with that before TMS, it would have been so different. I probably wouldn't have been able to deal with them as well as I do now. It helped me, and it's a different kind of well. I was okay before, but with TMS therapy, I really felt well, great, myself.
I love my job. I love being part of the process that allows someone to get their lives back and back on their feet. It is very gratifying. People come in a state of hopelessness, and I can help them see that life can be different. Depression is treatable. If medication does not work for you, there are other treatments. I would advise you to look into TMS therapy.
Innovative therapies like these may help cure what ails us.
Okay, that's it for this lecture. Head on over to Moodle to complete the last lecture activity, and we will see you next week for the final exam.